is that you're preventing years and years of literally suffering. I've had a number of patients actually come to me because their dentist said that they need a palate spreader. One woman came to me because the dentist told her kid that she needed a 9 tooth room. And I've done a lot of this work, and actually they've gone back to the dentist, and the palate had spread. They didn't need it, so there's a lot of dentists in my area who don't like me because they had to pay for their kids' college in other ways. But seriously speaking, most of the stuff you see, and you really have to remember this, and it's true when you start to do cranial work and you talk about people like TMJ, most of this stuff started way, way before they had the symptoms. Their state of despair, literally despair. We had a girl come to us, she was 15. She had worn braces for 2.5 years. That's what they told her she needed. And they had taken the braces off, and within less than 2 weeks of having the braces off, she couldn't open her mouth any further than this. So obviously they talked to the orthodontist, he was retiring, he transferred to this other orthodontist, and they basically said to this girl after wearing braces for 2.5 years that they would have to do the whole thing over. They literally came into our office crying, the mom, the daughter, in despair. She couldn't open her mouth. 2 weeks after wearing braces for 2.5 years. So we have another dentist around who I actually trust, and I started doing cranial work on her, doing the TMJ. Within 3 visits, she could open her mouth, and then I had him just make her a retainer that would actually help balance the jaw. And now she's 20, 23, 20. But she comes in when she comes home. No, she's still in college, so she's probably 21 or something. She comes home. When she comes home, she comes to check me. She's had no problem with the jaw. She can open her mouth. She could, it's like this was set up years and years and years ago. When dentists get them who are not functional dentists, they may make them look pretty, but they're going to cause a lot of problem and suffering years and years from now. So if you set up this paradigm early in life, a lot of those problems, the narrow palates, the high narrow palates, the cross bites, all that stuff will literally disappear. And it will go away. It will change, and it freaks people out because dentists never hear about it. It makes them a little crazy, or they tell them, oh, don't go to a chiropractor. But you can see, when you check a midline and you see that the bottom tooth is 2 or 3 millimeters from the midline of the right, that kid's going to, as soon as that dentist gets a chance, that kid's going to be in braces to fix that crossbite, at the best. So this kind of stuff is really important to look at, to evaluate, and make corrections. So for this one, the zygomatic fossa, which is the zygomatic malar technique, is a great one. The whole idea behind this is to make sure that these fossas, where the condyles, the mandible condyles are equal and patent. Because one of the things that happen is when the TMJ gets out of balance like that, then as the jaw starts to open and deviates to one side, the distal ligament that holds the posterior disc in place will start to stretch. And as it starts to stretch, what happens is the child starts to open and close their mouth, the disc starts to slide towards the top of the condyle, and when the ligament is still patent, it'll pull it back, and that's what that clicking is. When they open their mouth and it starts to click, it's the actual disc that's starting to slide over the condyle and getting pulled back. Well, if you do that for 20 years, it's either going to snap, and they're going to end up with the disc above the condyle, and their jaw's going to be locked, and it's going to be surgery, or it's going to move back and forth, it's going to start to calcify, and they're going to get arthritis in that joint. So this is a great way to balance that. What you're going to do is you make a flat hand contact over the frontal bone for stabilization. You take your index finger, or in little kids, I use my pinky, and obviously go up into the zygomatic fossa. You hold the pressure there, and you have the child bite. So you have them open their mouth, and then as they start to close their mouth, you follow it back and have them bite and relax. Very often in little kids, that's all you need to do. But the problem is, often that's not all you need to do. And this is where the fun comes in. So as you get them to bite, and if that doesn't change the process, as you get them to bite, you're going to take your finger, you move it superior, lateral to stretch the tissue, and then anterior, like you're swiping, making a swipe of the muscle. At the same time, this hand is going in the opposite direction. So what it looks like, I'm taking my jar off, my friend, here, is I'm coming up into this zygomatic fossa, I'm holding the frontal, I move superior, I rotate laterally, like I'm stretching the tissue, and I move inferior, and the whole time my frontal hand is making the opposite correction. You go back in and check the zygomatic fossas, they should be equal. Very often, after you make this correction, even if you're on the smaller one, you go back and you find that the first one you did was now smaller, and you have to do them both. This also makes a big effect on how the jaw tracks. If the jaw's tracking off to one side, and you reset this, very often it'll start to track the jaw immediately. This one here is called frontal sphenoidal maxillary correction, or Sutherland's cant hook. This correction is kind of about both aesthetic and functional. So let's say you've done your frontal correction, and you look at the head, and it's no longer high occiput. But when you look at it, you see that one side still looks like it's bulging, or one side still looks high, or one frontal still looks extended, or one sphenoid after you've done your sphenobasilar corrections. Very often you'll do your sphenobasilar correction, you'll get normal motion, but you look at it, and it still looks like there's a high sphenoid wing on one side. So if you have any of those issues, when you're done making your corrections, you balance the dura, you balance the respiratory, you balance the CRI, but you can still see one side is still swollen or big. This is what you do for this technique. Now what you do is you sit opposite the side of the correction. So if I'm going to correct the left side, I sit on the right side. What I do again is I contact the frontal. I'm going to take my hand in my mouth. Now I want you to look here. This is the pterygoid process of the sphenoid wing. It's slightly back and lateral behind where the last molar will be. Obviously, kids don't have molars. So the easiest way to find it is as you're sitting on this side, is you come along the line, the alveolar arch, you keep going back, and as soon as you fall off the palatine bone, you'll hit this little knob. It'll feel like a little knob. That's the pterygoid process of the sphenoid. If the patient can't take that because it makes them gag, which it does sometimes, you can actually hook it from coming in between the cheek and the teeth, and you can hook it this way. They won't gag if you do it that way. So there are cases where you can't get back here, especially if you have kids who have reflux. They tend to be very sensitive in the back of the palate, and you start to fidgeting that finger down there, and they will reflux all over you, which happened actually before we left. Anyhow, so what you're going to do is you take your contact on the pterygoid process, and on inhalation and then exhalation, you push the pterygoid process lateral and pull it a little anterior. And what you want to do is you want to feel the release at the sphenoid, the greater wing of the sphenoid. Once you feel that release, you hold the pterygoid process in that position, and you're going to do a fruit jaw. You move the frontal back and forth around it, and you'll move it, and as you're moving it, you will literally feel this whole tissue relax. And actually, this is one of those corrections where as you're doing it, you can actually see the swelling start to decrease almost immediately. As soon as you see that, you take your finger out. If you're working with someone older, and this pterygoid process has now calcified, and you hear a popping noise, what you do is you say, that was a great adjustment. It's going to be a little difficult to swallow for about 3 days. You'll be sore for about a week. And then just double check your malpractice that they cover intraoral, because you just broke it. It's not a long-term problem, but that's exactly what will happen. They'll have a little difficulty swallowing for about 3 days. It'll be a little sore, be a little tender for a week, and then they'll be fine. I've broken 2 of them in 30 years. Both of those people are still patients. And one of them is still waiting for the popping noise because she thought it was a great adjustment in her cranium. She's a little off anyhow. But yeah, she goes, wow, that was so great when you did that. I'm like, you were right. I couldn't swallow for 3 days. And it was so... Well, as long as you're right, you can tell them that you'll bleed out of your eye and you will only be able to see to the left after this adjustment. And they'll come in, you were right. I started bleeding out of my eye. But that was a great adjustment. So you have to be right. No matter how bad it is, just be right about it. Tell them the worst that could possibly happen. And then it'll be okay.
Dr. Rosen?
Yes, sir.
When you're disengaging the frontal bone with this adjustment
yes.
right here, are you bringing it lateral, leaning to the side of?
You're actually disengaging the sphenoid. You're actually disengaging the sphenoid. So you've dealt with this angle, the frontal zygomatic angle, and the swelling is coming because this part of the sphenoid frontal is not there. So you need to disengage the sphenoid wing, and then you just move the frontal around it. And what happens is the swelling in that joint is the small little blood vessels and stuff in there that are still kind of trapped, and as you do that, they will drain almost immediately. Okay? It's a great technique. You have to go slow. I use it a fair amount, especially when I'm trying to balance mountain bones. I am a really big sphenoid unlocker. I do unlock the sphenoid in a lot of different ways, so this is a really great way to start to do that. Let's do those 2, and then we'll start on the condition-specific technique. So you need to use fingers.